Hi, thank you for joining us for Exercise During Prostate Cancer, the latest evidence. My name is Phoebe James and I'm a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the lands we are all meeting on today. For me in Newcastle, it's beautiful Awabakal country, and pay my respects to elders past and present, and any First Nations people joining us today. Just want to mention before we start, this session is being recorded. The recording and the PDF slides will become available in our PHN Education Library on the PHN website in the next few days. We will have, if we have time at the end, we'll have a Q&A session. So please put your questions in the question box. There will also be an evaluation sent out at the end, and I would be eternally grateful if you could complete it for me. Today, presenting for us, we're lucky enough to have Lucas Nadiotis, who is the Program Manager and Senior Physiotherapist at the Cadence Center. I will now hand over to Lucas. Thank you.
Thanks, Phoebe. Thanks for having me on, everybody. So, as Phoebe mentioned, I'm Program Manager and Senior Physio at the Cadence Center. The Cadence Center is a purpose-built facility that started about 6 years ago, and what we do is we deliver targeted exercise to people going through cancer and cancer treatment. One of the big cohorts of people that we see is men that are going through prostate cancer treatment. So when presented with this opportunity, I thought I'd talk to you all about exercise during prostate cancer and what the latest evidence is in relation to this matter. Our centre strives itself on clinical excellence. So everything we do is ingrained in medical research. I'll turn my camera off for the presentation, and then, as Phoebe said, please just hold your questions at the end. We should have some time for me to answer them. So today I'll be running through prostate cancer statistics. We'll be looking at whether it's safe, or whether exercise, is safe, what type of exercise people should be doing, and the dosage that's involved in that exercise. We'll be looking at hormone therapy, and we'll be looking at the exercise that is done alongside that and the latest clinical trials. I'll also talk about exercise prescription when it comes to bone metastases, and finally just indicate and show you what is offered at the Cadence Center and how referrals can be put through. So prostate cancer incidence. The estimated number of new prostate cancer cases diagnoses in 2022 was 24,217. The prostate cancer made up around 27% of all new male cancers diagnosed in 2022. The estimated number of deaths from prostate cancer specifically was 3,507, and the estimated percentage of all male deaths from cancer in 2022 was 13%. Chances of surviving at least 5 years, so from the years 2013 to 2018 when this was studied, was about 96%. And males living with prostate cancer at the end of 2017, diagnosed in the 5-year period from 2013 to 2017, was 89,005. So prostate cancer was the most commonly diagnosed cancer in Australia in 2018, and it's estimated that it will remain the most commonly diagnosed cancer in 2022. So this is just a graph to show you about the number of new cases, and as you can see, there's a significant difference from prostate cancer to the next, which is melanoma of the skin. So we're looking at just shy of 25,000 in the prostate cancer side, and your next is then melanoma, which is just above 10,000. So it's interesting to note that the least diagnosed cancer in men in this year was the stomach cancer. As you can see here as well, the graph outlining survival. So In 2014 to 2018, individuals diagnosed with prostate cancer had a 96% chance of surviving for 5 years compared to their counterparts in the general Australian population. Between 1989 and 1993 and 2014 to 2018, the 5-year relative survival for prostate cancer improved from 63% to 96%. So obviously the treatments that we have taken on and the adaptations and changes in medicine have gone a long way towards helping this population. Who gets prostate cancer? Well, when we consider these factors, if you look at age, the risk of being diagnosed increases with age. So it's more so your older community. Family history-wise, if you've got a direct relative, that more than doubles your risk. Black African and Afro-Caribbean males are the highest at risk. On the genetic front, a man can inherit genes that can increase his risk. So the genes, I believe, there are the BRCA1 and 2 and the HOXB13. It's also been linked to diet, so high levels of processed meat and a diet high in fat is what it's been linked to on that side. And lifestyle-wise, low physical activity and exercise levels can also be a contributor. When it comes to treatment options, the treatment depends on the stage of the disease, the location of the cancer, the severity of the symptoms, and one's general health and wishes. So the main options are your watchful wait, your active surveillance, surgery, radiotherapy, cryosurgery, hormone therapy, which is what we'll be delving into today, chemotherapy, and immunotherapy. The first question that I generally get from medical practitioners and from patients is exercise safe to do? The short answer of that is yes. So the American College of Sports Medicine noted that exercise is safe for cancer survivors and that inactivity should be avoided. A few years ago now, COSA, which is the Clinical Oncology Society of Australia, put out a position statement on cancer and exercise. And they basically stated that exercise should be part of standard practice in cancer care and be viewed as an adjunct therapy that helps counteract the adverse events of cancer and its treatment. So, exercise is safe depending on who's prescribing it, what factors they've considered, have they looked at one's detailed medical history, the current history, do they understand the treatment regimes, the boom and bust cycle? Also, have they looked at the side effects that one may be experiencing? Another thing to look at is bone metastases, and these must be considered before exercise is prescribed. We'll touch on bone mets a little bit later, but all those factors that I've mentioned, if that's considered, one should be able, a trained clinician should be able to put together an appropriate exercise program that is safe for the person. Excuse me. Dosage is another question. So there's a few things, a few different sources out there on dosage. Traditionally, what we recommend is 3 by 30 minutes of moderate aerobic activity per week. So that's things like swimming, walking, riding a bike, anything that gets your heart rate up. In addition to that, we recommend, or the recommendation is 2 to 3 weight sessions. The question is this achievable? And those figures might be slightly different to what people are normally used to. So most of your literature will recommend 5 lots of 30 minutes of aerobic exercise per week, plus the 2 to 3 weight sessions. However, in the reading that I've done, it's becoming clear that people are finding this quite challenging. So even your healthy populations may not necessarily be getting 5 lots of 30 minutes aerobic exercise per week. And these are people that do not have this disease stopping them. So certainly at our center, what we find is that people are struggling to meet the 5 by 30 a week. And the 3 by 30 is a lot more achievable. So when you consider factors like people being on the treatment, they're busy with work, they have their children or grandchildren to look after, they're constantly being pulled left, right, and centre for treatment regimes, they're generally fatigued and unwell, it really has an influence on this number. And so potentially there's questions relating to whether the 3 by 30 will now replace the 5 by 30 minutes of aerobic exercise per week. So ADT, or androgen deprivation therapy, is common amongst men that are undergoing prostate cancer. So approximately 40% of them will receive ADT within the first 6 months of diagnosis. The way this works is it suppresses the level of androgens made by the testicles. Now, androgens stimulate prostate cancer cell growth, and the main androgens in the body are testosterone and dihydrotestosterone. Most androgens are made by the testicles, but the adrenal glands, as well as the prostate cancer cells themselves, can also make androgens. So lowering the androgen level or stopping them from getting into the prostate cancer cells oftentimes makes prostate cancer shrink or grow more slowly. As we know, ADT extends the lives of many men with prostate cancer. However, this benefit comes at a significant cost of side effects. So let's look at some of the side effects that men undergoing prostate cancer treatment do experience and how exercise can help. First of all, changes to body composition. So men gain weight, they decrease in lean muscle mass, they increase their fat mass, and increase abdominal adiposity when testosterone is culled from the body. In the study by Cormier in 2015, there were 63 males on ADT, and they were randomly assigned to a 3-month supervised exercise program comprising of aerobic and resistance exercise. 32 men were in the exercise group, and 31 received just usual care. The primary outcome that this study looked at was body composition. A 3-month exercise program preserved appendicular lean mass and prevented gains in whole body fat mass and trunk mass. The improvements were also seen in peak oxygen consumption, muscle strength, sexual function, psychological distress, social functioning, and mental health. Exercise significantly improved treatment toxicity while improving social functioning and mental health. So concurrent prescription of supervised exercise when initiating ADT is therefore advised to minimize morbidity associated with severe hypogonadism. It's also important to note that metastatic prostate cancer patients can still exercise and maintain body composition and improve strength. Bone health. Testosterone is an important hormone for maintaining healthy bones. Current evidence suggests that men with testosterone deficiency have a higher risk of developing osteoporosis and experiencing fractures. So essentially, testosterone and its metabolites are essential for bone health. ADT is associated with a decrease in bone mineral density, an increase in bone turnover, an increase in fracture risk, and an increase in osteoporosis risk. A study by Tafe et al. In 2019 basically found that exercise can maintain bone mineral density and not necessarily increase it. So this is something really quite important that we mention to patients is once you start on the hormone therapies, start on bone loading type programs or impact type exercise, as there's no point waiting until one is osteoporotic to try to fix the issue. Cardiovascular disease and prostate cancer. So ADT leads to an increased risk of cardiovascular disease, including myocardial infarction, hypertension, and stroke. Exercise prompts favorable changes to the risk factors associated with cardiovascular disease, excuse me, but there is no research on cardiovascular disease incidence and mortality after treatment. Excuse me, I'm just getting a tickle in my throat. I might just quickly grab a sip of water.
Is everything all right, Lucas?
Sorry about that, just a throat tickle. I should be good now.
Okay.
My apologies, everybody. When we combine exercise in this space, we've looked at blood markers and also body composition. So as noted, the HDL and total cholesterol decrease, triglyceride levels decrease, insulin sensitivity increases, and on the body composition side of things, weight decreases, lean body mass increases, and fat mass decreases. So there's a consistent association between ADT and increased risk of cardiovascular disease. Sorry guys, this throat tickle is on top of me. Can I just pause for a couple of minutes, Phoebe?
Oh, it's just that everyone's here, so unfortunately not.
Okay, can you put up with my coughing?
Sure, do you have water?
I have had a sip. It should be gone in a second, sorry. I don't usually do this much talking.
No, and it is going around at the moment.
Sure is. Sorry, I'll try to keep going. So there's a consistent association between ADT and the risk of cardiovascular disease. The type of ADT and the pre-existing cardiovascular history also seem to play a major role in the risk of subsequent cardiovascular events. So the majority of evidence in this space is observational. The Bosco study of 2015 was a meta-analysis of 8 observational studies and showed a 17% increase in cardiovascular disease when on ADT. Separate observational studies by O'Farrell in 2015 compared the cardiovascular health of 41,326 men with prostate cancer on ADT to 187,785 men without prostate cancer. And the risk of cardiovascular disease was higher if treated with ADT. The conclusion is that there should be a solid indication for ADT in men with prostate cancer so that the benefit of the treatment potentially outweighs the harm. A possible mechanism by which ADT may increase the risk of cardiovascular events is due to metabolic abnormalities. So increasing body weight, reducing insulin sensitivity, dyslipidemia, and activation of T cells to the Th1 phenotype can result in atherosclerosis. When looking at atherosclerosis, exercise has an anti-atherosclerotic effect, so it prevents the blood vessels from narrowing further. It's anti-thrombotic, so it prevents blood clots. It's anti-ischemic, so it helps deliver blood to the heart. And it's also anti-arrhythmic, so helps maintain a normal heart rhythm. So the takeaway message there is that exercise decreases the cardiovascular risk mortality by 25%. Diabetes and prostate cancer. Most men with diabetes are obese, and obesity is associated with a greater prostate cancer mortality. ADT is associated with an increased risk of developing diabetes and exacerbating existing disease. It causes a negative change in insulin regulation and lipid levels, and it also causes a change in body composition, as we mentioned earlier. So management, of course, exercise, weight management, diet, getting people to cease smoking and decrease alcohol intake. There's pharmacological management and also blood glucose management. On the exercise side of things, exercise will enhance glycemic control and improve insulin sensitivity. It reduces dyslipidemia, improves body composition, people reduce their insulin or the medication they take, and this also helps reduce blood pressure. So it's important to note the weight, but not prevalent diabetes is associated with greater prostate cancer mortality in men receiving combined modality treatment for locally advanced disease. Cancer-related fatigue is another big symptom that we'll oftentimes see. So this is the distressing, persistent, and subjective sense of physical, emotional, and/or cognitive tiredness or exhaustion. It's not generally proportionate to the recent activity, and it isn't relieved by rest or sleep. It'll affect 3 in 4 prostate cancer patients, and it can range from minor to severe. It can also last from months to years, and it can oftentimes continue after treatment ceases as well. What we do know about it is multifactorial. So things like stress, change in sleep patterns, change in diet, constant travel to appointments, the body trying to repair itself, all influence and can affect this. It also involves interrelated cytokine, muscular, neurotransmitter, and neuroendocrine changes. In the Bowie study of 2017, it pretty much indicated that exercise reduced cancer-related fatigue and improved quality of life in prostate cancer patients receiving ADT. What's important to note about this study is that it's only applicable if people are suffering from a small to moderate amount of fatigue. Exercise and the effect on severe fatigue is at this stage still unclear. Urinary incontinence is another big one that we see. There's a few different types of incontinence. So stress incontinence is the loss of urine with a cough, sneeze, laugh, or lift. Urge incontinence is the frequent urination with episodes of leakage. And overflow incontinence is involuntary release of urine from an overfull bladder. The Salient and Osbas study of 2018 was a randomized control trial following a radical prostatectomy. So here they had an experimental group which did pelvic floor exercises in the 3-month perioperative period prior to having the prostate removed. They also had a control group that did no exercise. So in the first month post-surgery, the experimental group, or the group using or doing the exercise, used between 1 and 3 or 4 to 6 pads per week. The control group used 5 pads per day. 6 months post-surgery, the experimental group, let me just start that again. So the first month, the experimental group used between 1 to 3 or 4 to 6 pads per week. And the control group, used 5 pads per day. 6 months post-operatively, the experimental group never used a pad, and the control group was still using 1 to 6 pads per week or 3 to 4 pads per day. So quite significant there. Erectile dysfunction and loss of libido. In the study by Cormier in 2013, early observations indicated that exercise maintains sexual desire during ADT. Currently, research is being conducted to explore exercise as a potential management strategy. Psychological distress. So men with prostate cancer showed a significantly higher risk of psychological distress compared to men without prostate cancer. So they're dealing with issues and things such as the challenges of prostate cancer, the unknowns, the uncertainty of how they will feel on the treatment. They're confronted by the way they change secondary to their loss of libido, and this reportedly makes them feel less like a man. They also feel less confident, and then they tend to isolate, and men tend to isolate themselves. So what we find is that women will talk face to face and men will talk shoulder to shoulder. So in our clinic here, when men are exercising and we have a prostate cancer group that's doing their exercise session, won't look at each other and talk, but they'll be exercising next to each other and sharing stories and talking, which we think is really beneficial. So there are two studies to note here. So in the first study by Cormy, she noted that exercise has an antidepressant effect as it was linked to traditional masculine values and traits. Participants in the study noted a focus on their prostate cancer and side effects prior to the involvement in the exercise program. This was associated with poor mood and a lack of general motivation. The exercise, however, provided men with a constructive activity to look forward to and empowered them through participation. It improved their confidence and helped them gain a sense of purpose and control. In the second study, they looked at the long-term effects of exercise on psychological distress, again in men with prostate cancer on ADT. There were 135 patients aged between 43 and 90 on ADT, and they were randomized to 2 times a week supervised exercise programs. They either did impact loading and resistance training, aerobic and resistance, or just usual care. And this continued on for 12 months. So the scale they used was the brief symptom inventory, or the BSI-18, and this was used to gauge their distress. There were significant interactions for depression and anxiety, and it was concluded that various supervised exercise modes are effective in reducing psychological distress in men with prostate cancer. Those with the highest level of psychological distress improved the most, and supervised exercise should be prescribed to improve psychological health in prostate cancer on patients with ADT. That was their recommendation. So bone pain for us is a big one. As you know, bone pain in advanced prostate cancer occurs where the cancer has metastasized to the bones. 80% of men with bone metastatic disease will experience bone pain. And it's a pain that's described as a toothache, a dull ache, or a stabbing pain. It can cause compression fractures and other pathological fractures, which is why it's so important to get the exercise prescription right in patients with bone metastases. They tend to experience night pain, and this is particularly so in the spinal cord, which for us is a red flag. We usually refer people back to their oncologist to discuss this and get an MRI to rule out anything sinister. Exercise, when appropriately prescribed and monitored, is safe and can be well tolerated. It can lead to improvements in physical function, physical activity levels, and lean mass. In one study, 20 men with advanced prostate cancer were randomly assigned to a 12-week resistance exercise program where the exercise was based on the location of the bone lesion. We also had a control group. 65% of participants had 2 or more regions affected, and the outcomes that were looked at were attendances to the program, of which there was an 83% attendance rate, the compliance rate, which was 93% of those 83% that attended, changes in physical function, physical activity level, lean mass, and all of these showed significant differences between the groups. So it's important also to note that there were no adverse events during this exercise. There were no incidents of bone pain that was negatively affecting the participants to be able to undertake the exercise. The only downside to the study was that it had a small sample size. This is a table that we use when it comes to prescribing exercises for those that have bone metastases. So credit here goes to Prue Cormy, who put this together. So as you can see on the left-hand side, we have the metastases site. Then going up the table up the top, there's resistance exercise, aerobic exercise, and flexibility. So the way we work it is we look to see where the site is. So if, for example, it is the pelvis, it's okay to exercise, to do resistance exercise in the upper body and in the trunk. But if we're looking at the lower body, there's a couple of provisos. So we've got a tick and 2 stars. If we scroll down here to the bottom, the 2 stars are exclusion of hip flexion or hip extension and flexion, and inclusion of knee extension and flexion. So this is how we would apply this to our patients to ensure that what we're doing is appropriate and is safe for them, depending on the site of the metastasis. This is just a slide that summarizes the side effects depending on the different course of treatment that someone's having. So it's broken up into surgery, radiotherapy, hormone therapy, and chemotherapy. I won't run through this in any detail, but I just thought it was an interesting page to put in. So all that was mentioned above is practice that we're familiar with here at the Cadence Center and that we try to apply. So as I mentioned, it's all evidence-based work that we do. We are a not-for-profit and we specialize in exercise oncology. We're there to support and provide guided, personalized exercise programs to those going through cancer or chronic disease. So essentially, we translate the research into practice. The services available, really there's 2 avenues. There's a home program for people who are far away and who don't have any access to services in their immediate location. Or for those closer to the Newcastle area, we have an in-clinic program. We're staffed with physiotherapists and exercise physiologists, and everyone has done additional training and professional development in the cancer space. Generally speaking, every patient who attends our service has an initial assessment. We'll gather information subjectively, so we'll get their medical history, understand their treatment, their side effects, what stage they're at, when they were diagnosed, if they have any musculoskeletal issues. Once we have this information, we'll put them through some physical tests to gain some objective measures. This allows us to find their baseline level of function, and then based off of all this, we'll prepare a program for them. That's a 12-week program if they're in clinic, and we can also do a 12-week at-home program that's either paperless or that they can access online. We also write a letter back to the referrer outlining our findings and discussions with the patient, so the medical professionals are kept on track. Medicare can be used to help subsidize this as part of a TCA or EPC, or people can use private health. On our website, there's a doctor's referral tab up the top. If you simply click on that, that takes you to this page where we can have the rest of it filled out, and that'll automatically send through a referral directly through to us. The home program looks like this. So for people who are further away and do want to access services, there's a members portal where they can log in, and we'll have an individual tailored program put together for the patients that they can log in via any electronic device and simply follow. So they can do that in their own home or in a gym close to their place, whatever they see fit. References and questions. Thanks for listening, everybody. I apologize for the coughing fit.
Thank you so much, Lucas. We haven't had any questions come through, which is a bit of a shame. If anyone's a particularly quick typer, maybe we'll get to them. As I said, this presentation recording and the PDF slides will be uploaded to the education website. And I want to thank Lucas for spending his time and energy creating this. he already has a 9 to 5 and a very busy schedule. So not only has he taken time to create this presentation, but also the time to present it to us. So we're very, very grateful. Thank you to everyone who has joined us as well. Oh, we did have a question come through. Thank you, Gemma. It's, do you know of any similar services on the Central Coast?
No, I don't. So we're the only charity of this kind in the country. Depending on what drug the person is on, it will depend on what programs they may or may not be able to access. So the MAN plan, for example, if someone's on Lucrin, then they're then eligible to attend this MAN plan program. I believe the MAN plan has multiple sites around the country. So if the referral is put in with that, they will then link the patient in with the site closest to their home.
Okay.
I don't know if that's helpful at all, but otherwise there aren't any others that do this that I know of.
Do you accept referrals from other physios?
Yes, we do. So not everyone needs a referral to attend. Because we're allied health here, we can take people on without a referral. However, in our pre-exercise screening, if we deem that the medical team needs to know about certain things, then we'll refer the patient back to get clearance from their GP prior to exercising.
Perfect. And it's not really a question, it's just an observation that has come through from Michael. He appreciated the distinction regarding exercise for strength gains versus exercise for self-esteem and social engagement, which is what you guys are really about.
Yeah, great.
Okay, well, thank you for spending your lunch breaks with us, and thank you again, Lucas, for presenting. Really appreciate it. And everyone needs to look after each other and themselves.
Thanks so much, Phoebe. Thanks, everybody.
Thanks. Bye.
Bye.